Welcome this evening to the new Grand Challenges Forum, our second installment of the semester. Our speaker tonight is Dr. Joshua Ellis. Joshua Ellis grew up in San Antonio, Texas, and went to Judson High School, where he was a varsity football player and a state champion runner-up, as well as an international baccalaureate diploma candidate. He graduated from the Honors College, so as I told you all, he is an alum at the University of Houston in 2012, with a major in history and a minor in medicine and society. While obtaining his bachelor's degree, Josh served as Honors Ambassador's President. He became the recipient of the Honors College Outstanding Senior Service Award, the Honors College Arete Award, which is our most esteemed award for our students, and the sole recipient of the University Dean's Award his senior year. Now, I also want to add, which I've already told my students, Dr. Ellis actually somehow convinced all of our human situation professors that it was a good idea to get pied in the face for a good cause. And so if you all remember this, some of you who are on the call tonight, we had pie a prof, and I mean, it should be brought back. It has not been brought back since. And I think it was done for like 3 years, 3 of the 4 years that Dr. Ellis was with us in the Honors College. So you know the human situation professors, well, students paid money to throw pies at their faces, and it was all for a good cause. Invisible Children was the cause that Dr. Ellis was actually collecting money for. So back to Dr. Ellis. He then went to the Howard University College of Medicine. I think when I talked to him the first week he got there, he said he had reached the Mecca. And so he went to the Howard Med, and he graduated there. From there, he was, he served as class vice president and the president of the International Medicine Interest Group while there. He finished med school in 2016. And he then went to complete his residency in emergency medicine at the Mayo Clinic. While at the Mayo Clinic, this is amazing, Josh was the recipient of the Gold Stethoscope Educator of the Year Award and also the Gold Humanism Award, both given to just 4 out of the 1,793 physicians. He is the only person to have ever won both awards. After having completed residency, Josh is now working as the current medical education fellow at Harvard Medical School and the Beth Israel Deaconess Medical Center. He is also simultaneously pursuing his master's degree at the Harvard School of Public Health. Josh was a recipient of the 40 Under 40 Leaders in Minority Health Award by the National Minority Quality Forum in 2020. Additionally, most recently this month, Josh accepted a position as a full-time academic faculty physician with the Harvard Medical Faculty Physicians Group beginning in 2021. So anything is possible if you graduate from the Honors College at the University of Houston. Okay, so without further ado, please all, let's welcome Dr. Joshua Ellis.
Thank you so much, Dr. Lowe. It is such an honor and privilege to be back here at the University of Houston. It feels like a homecoming, and also it's just full circle, and just really an honor to be here. I've been keeping up with the new Grand Challenges Forum. I've heard about it for a couple of years now, so I'm excited to be part of this as well. My talk is called Racism in Medicine and a Pandemic Within a Pandemic. And this is actually a lecture I've given a couple times. Initially, it was done at Mayo Clinic for a Grand Rounds presentation. Essentially, it's branched off into a number of different presentations that I've taught at Harvard Medical School, and most medical students who pass through our emergency department have received a similar lecture. So I'm excited to bring it back to Houston, and let's begin. I'm excited. So no financial disclosures, but University of Houston, I'm open to them if you guys are wanting it. But I do have obvious biases, which is relevant in this lecture. So this is a picture of my family here to the left. I'm a descendant of an African-American man, and my mother is Mexican-American and a descendant of an undocumented immigrant. And these are my 4 siblings. My youngest sister is pretty severely special needs, but is about to unbelievably turn 18 this year. So this picture to the right is a house my father was born in and my grandfather's house. I spent some of my childhood in this house, and so I was born into a low-income family. So much so that the last 2 years of my high school experience, I actually was considered homeless by the state. And thanks to the McKinney-Vento Act, I was allowed to bus into the school district that I originally started my high school in, at Jefferson High School. And so in the mornings, sometimes I was taking 2 city buses to school in San Antonio, and then 2 city buses after football practice back home while keeping up with curriculum. I'm also a proud member of the LGBT community. And so all in all, here are the biases in my background story I present, and you can hopefully take that as I present this information to you. I do have some objectives here. We're going to talk about a shared vocabulary regarding health equity. We're going to contrast different types of racism and how that term is used in modern society, and also inside healthcare. We're going to present a variety of racial disparities in healthcare, and we're going to talk about the concept of subconscious bias and the implicit association test. And we're going to talk about previous interventions that have improved health disparities, and lastly, talk about the racial demographics relevant to U.S. healthcare. And so let's begin. So this is relevant in this because of the pandemic, and I think it's coronavirus has done a number of things. Well, it's completely impacted every person in America and in the world for that matter. But one alarming thing it's done is really shed light on some underlying health disparities. Because as you can see, we've noted that Black patients are 3 times more likely to contract coronavirus and 6 times more likely to die from it. And there's such an infrastructure and history of inequity that leads to this type of result. And so it's become more relevant than ever to talk about racism, racial disparities, and health equity, thanks to the coronavirus. And so just because it shines such a light on these disparities. To begin this lecture, and that's just putting in context as to why this is such an important topic now, but to begin this lecture, we'll talk about these shared terms. And these are some of the goals I have in vocabulary, which we're going to define, beginning with race. And so race, if you get nothing else from this part of this lecture, I want you guys to know that race is a social construct. In fact, the history of race goes back to, in fact, early days of slavery, in which they were trying to justify the treatment and enslavement of African-American people. And then there's centuries of scientific research and work that went into trying to prove the biological differences of African-Americans. And it's now come to terms that there's actually very little differences in the genetic makeup or any biological difference that would necessitate defining race in a biologic or medical manner outside of a very few illnesses. But why do we need to keep talking about this? So in 2016, a study was done in Virginia where they studied probably over 200 medical students, and half of the white medical students still believe myths such as Black people have thicker skin or less sensitive nerve endings. And we're talking about the pinnacle of educational success. These are not low education people. These are people who have surpassed much of the pre-meds in this room here and still believe these myths. And so this would be an example in which they're using it in a biological manner. But at the same time, we can't just simply forget race, right? It could be a social construct, but we can't forget it, right? It's clearly having an impact, and coronavirus is a good example in which that impact is so relevant and something we need to pay attention to. So how are we going to use it? Dr. Kamara Jones is a famous civil rights activist and a physician who actually defines the variable race more as a construct of the society around it and basically captures the impact of racism. And this is powerful because it's such a difference. You couldn't go around and say, ignore the impact of growing up African-American in America or Hispanic American in America or white in America. And all these impacts have an effect on the person who comes out to be. She actually has a famous paper called A Gardener's Tale, and I encourage everyone to get a chance to read it. It's a simplistic analogy in how the development of race inside America has led to our outcomes and how that has actually it defines or actually describes how the social construct is actually capturing the impact of what racism is, right? So now our next question is, what is racism? If race is solely a product of racism or a definition defined by racism, what is racism? And so it's a very commonly used term, and it ranges from a devastating pejorative in American society, so much so that here's a 2014 billboard in Arkansas. It's funded by the Knights Party, which is a branch of the KKK. And even the KKK has this billboard that says, "It's not racist to love your own people, white pride radio." And the takeaway is the KKK doesn't even want to be called a racist. White supremacists are fearful of this word just as much as anyone else. And I found it to be very much the case, right? I feel as though using a racial epithet against a minority person is just as harmful as using or calling a white person a racist, all right? And so, and on the other end, this phrase, here's a show called The Dear White People, or called Dear White People. It is one of my favorite shows. It's on Netflix, shameless plug. I remember hearing about it when I was in college, and it's a great depiction of racial identity in a predominantly white institution of higher education. And this is Sam White, the protagonist, or one of the main characters, and she states to the dean of students in a very confident manner that Black people can't be racist. Prejudice, yes, but not racist. Racism describes a system of disadvantages based on race, and Black people can't be racist since we don't stand to benefit from such a system. I don't agree with Sam White in this, but she's clearly using this word racist and racism different than the Ku Klux Klan was inside the previous billboard. And Dr. Kamara Jones inside her Gardner's Tale actually does a good job of separating racism into 3 different categories and using that analogy of the Gardner's Tale. And she talks about internalized racism, and that's self-hate and reflective of a community who has disparaging thoughts of themselves, which isn't a product of that person being deficient. It's actually a product of growing up in society. If you grew up in society and you're an underrepresented minority or a marginalized population, there is a good chance that you've been exposed to a lot of the rhetoric and the social impact of racism on yourself. And there's personally mediated racism, which is like your prejudice, your discrimination, the one-on-one impacts, and then there's structural racism. And this is interchangeable with institutional racism, structural racism, and it basically describes the historic and societal disadvantages, the government policies, all the things in place that disadvantage one group of people based solely on race. And so let's talk about individual versus structural racism and its impact on healthcare, right? And we'll start with cardiovascular disease because it's such an easy and common subject, but it's also it's the #1 reason for death in the United States. And we can look at this. This is all taken from the CDC on these charts. And pre-meds in the room, I want you to know this is a chart and study heavy lecture because I want you guys to get training in how to read a chart really quick. And so this chart here on the left is a depiction of death rates for African Americans versus other races. And you can see this green bar is on top, and it's substantially higher for the last 20 years than all the other races. And pretty much double that, if not, it's greater than double our Asian counterparts. And then we look at all the predisposing factors, and just to summarize that, it's more than twice as likely to die by heart disease than our Asian counterparts as an African American. And we can look at some of the risk factors for cardiovascular disease, such as hypertension, obesity, diabetes, and we can see this green bar being African Americans is higher in every single category. Right? And so all the risk factors for cardiovascular disease in this population are worse. And these are racial disparities. And we have to ask ourselves why, right? And what we've been able to point to very much so is institutional or structural racism, and also describe these social determinants of health, right? And SDOH is an acronym for that. And if you look at this chart, we can go to each category. Economic stability has been shown time and time again to have an impact on your cardiovascular health. If you're a low socioeconomic status, you're more likely to have cardiovascular disease and die from it. Well, we have to talk about the income gap from the average white family to the average Black family. And it's in 2019, it was actually measured to be about $700,000 difference, average, right? Obviously, I'm not saying every white person at the University of Houston has a family wealth income of $700,000, but we also have to talk about modern impacts of economic stability and racism. For example, if your name is typically African American, the Harvard Business Review did a study that showed in 2019, if your name is typically African American, you're less likely to get hired or called back for an interview when you have the same resume as somebody with a white name. And they actually repeated that study from 20 years ago, and they found pretty much the same data. 38% less likely chance of getting offered an interview if you simply have a different name, right? And we can talk about the neighborhood and built environment that you're in, and even just physical environment, right? African Americans are much more likely to have mass incarceration. And I believe in 2010, it was something 20 times more likely to be incarcerated for drug-related offenses than their white counterparts. And we've seen drastic impact on cardiovascular disease with any amount of time in the prison system, right? We also know that thanks to redlining and gentrification and a number of policies, we've seen that these neighborhoods have poor housing conditions, There's food deserts that are more likely to be in minority communities. And if we go over to health and healthcare, right, health insurance is still less like, African Americans are still less likely to have health insurance, even after the Affordable Care Act. And we can go to education, right? Thanks to property taxes being a primary means of funding education in America, the segregation, the redlining, the income inequality has led to a greater than $20 billion deficit inside education gap between the African Americans and white Americans in society. In every single one of these categories, we've demonstrated that there's a higher risk of hypertension, diabetes, and cardiovascular disease if you have a deficiency in them. And so these are examples of how institutional racism and structural racism has already predisposed African Americans to these exact disparities I just described. But that doesn't stop there. That doesn't mean we're completely free as physicians. This lecture is typically given to Harvard medical students. And so I always like to make sure we're still talking in a pre-med or medical manner. It doesn't mean we're free from actually being part of the process that's causing these racial disparities. Now, I'm an emergency medicine doctor, and so what we're going to do is talk about emergency doctors and how we have an impact individually on the care of patients that leads to these same disparities, right? And we're going to go through a number of cases. And for all the pre-meds in the room, we once you get in medical school, you would do a great amount of case-based learning. So all education essentially and questions and presentations are going to start with a case, right? And so here, I'll read it out to you. A patient presents to the emergency department with chest pain. He is diaphoretic, another word for sweaty, and visibly uncomfortable. He notes that he was walking up the stairs when the pain started, and it radiates to his left arm. If you guys don't know this now, this is a tall tale sign of a potential heart attack. And every person who has a family member over the age of 50 should understand that this is quite concerning, right? And the question is, how can the race of this patient have any effect on his care? So what we're going to talk about is racial disparities in the emergency medicine management of chest pain. And we're going to go through every step of the process and demonstrate how individual personal racism has led to disparities in each part of this process. And so starting with triage, right? And so triaging is very important. There's a reason if you go in the emergency department with a cut on your arm, somebody's going to fly by you if they have concerns of a stroke or a heart attack, because there's a time-sensitive illness, and we prioritize that in a number of things. And there's a reason if you're young and healthy, you wait for 5 hours, and if you're over the age of 80, you're going to get seen quicker. Well, let's talk about this study. It uses an emergency severity index score, which is how they're measuring the triage. The higher the score, the less likely you need to be seen immediately, and therefore the longer your wait in the waiting room. And you look at these two big chief complaints, and chest pain is the second highest chief complaint that causes death in the emergency department, and it's the highest litigious one. So the most likely reason you get sued as an emergency medicine provider. And there's about a 20-point difference on the scale that they're using between African Americans and white patients. And then the same thing with shortness of breath, which is another major killer in terms of chief complaints in the emergency department. And to compare and contrast how big of a difference that is, there's only a 4-point difference in abdominal pain. So that's quite a concerning difference, right? And what does that mean if you're triaging separately? Well, more so, we've seen the same triage scores in the pediatric population. They've controlled for a number of different diagnoses, such as breathing difficulty, abdominal pain, an objective diagnosis like an objective fever. And they looked at patients who would eventually require hospitalization. And this is in a pediatric population. So we're seeing the exact same findings in children, right? We see the exact same findings in the Veteran Affairs Department, right? So our veterans, right? And they're being treated differently. If you look at this chart, their red dashed line are Black patients in both charts, and the black straight line is the white patient, right? And this is a pain score, which certainly is a subjective measurement, but you can see that an African-American patient in this study basically had to have a pain score of 10 to even come close to the triage rate that a white patient would have with a pain score of 0. And remember, the emergency severity index score, the further down it is and lower the number, the more likely you'll be seen immediately, right? And then we go over here, this is a measurement of heart rate. It doesn't get even out until we're about 180 to 200 beats per minute, which is a deadly rate. You're pretty much being rushed in an extremist situation at that point, before these disparities start to disappear, right? And now, once you get triaged through, right, what is the likelihood that you get basic diagnostic tests that are appropriate for chest pain evaluation in the emergency department, right? EKG, cardiac enzymes, a cardiac monitor, or even pulse oximetry, having your oxygen measured, were less likely in African Americans and Hispanics than their white counterparts. And this is a study of over 78 million visits in over a 10-year period. So this is big data nationwide, right? And we're finding all these disparities. Now, once you get the right test ordered, what is the likelihood that you have to wait longer for this initial EKG than your white counterpart? And now, if anyone's ever taken ACLS or any of our pre-meds have shadowed, there is a big metric inside American healthcare. It's a nationwide metric and the gold standard of care for an acute myocardial infarction, which is otherwise known as a heart attack. It's also synonymous with ACS, which is acute coronary syndrome. These are all interchangeable words. But the door to PCI time, which is a cath lab, right? The gold standard of treatment is 90 minutes. Every single hospital has a goal to get their patients from door to cath lab in 90 minutes. So if you're African American, you actually have to wait 11 minutes longer, less than or double the amount of time than your white counterparts, if you in fact actually have a heart attack. And the reason they separated those with a heart attack and those without, because there's a number of different types of chest pain that come to the ER. You have the people who are sweaty, clutching their chest, look ill, and then you have the people who sprain the muscle from throwing a baseball, right? And both of those have disparities, but the one that's more important is this doubling of time to just get the initial test, right? And to put it in perspective, that is 12% of your door to cath lab time already lost just for the sake of being Black, right? And this study has been repeated in a number of settings, right? And now what about once you get the test, what is the likelihood they'll miss your diagnosis of having a heart attack, otherwise known as a myocardial infarction? So non-white patients were actually 2 times more likely to be discharged from the emergency department and 4 times more likely to just have the entire diagnosis missed. And this study wasn't even a study that was designed to look at racial disparities. They were looking at all the reasons for missed myocardial infarctions, including the age, a normal EKG, your gender, your chief complaint not actually being chest pain, but shortness of breath. They found that non-white race was such a predisposing factor that they put it down here in a whole separate category next to normal EKG, right? And so a normal EKG, obviously one of the diagnostic tools not giving you the diagnosis, it would be a high reason to miss on the heart attack, but to not be white gives you about 4.5 times, if you're reading odds ratios, hopefully some of you pre-meds have started taking biostats, about 4.5 times more likely to have this misdiagnosis if you're non-white, right? And so just to recap, every single step of the way in your management of chest pain that leads to a disparity in these outcomes, and this outcome would most likely be death from a heart attack. There is an individual component and an individual component of racism that has a deleterious impact on the patient's health. In addition to the structural racism that makes these patients already predisposed, right? These are the patients that are most vulnerable, most likely to die from heart disease, most likely to have all the predisposing factors. And here we are treating them individually in a different manner. Case 2, and I hope you guys are on board for this. I'm presenting a number of different topics and variety of cases so that, because there's so much data out there on racial disparities, and really this is such a creative way in which we're finding them and discovering them. So patient is a 23-year-old otherwise healthy male who presents to the emergency department with a diagnosis of appendicitis. He's otherwise healthy and presents with his fiance. Vitals are normal except he's febrile. How can the race of this patient have any effect on his care? And what we're going to talk about next are racial disparities in pain management, right? And this is actually a fascinating topic for me, right? And then this was one of the original racial disparities discoveries that was so profound, right? Because we're treating our African-American patients differently than our white patients for just pain management. And this was actually started before the opiate epidemic, right? And so this was when pain was a vital sign. A very important part of managing patients is managing their pain. And this study actually, if you see, the black bar is white patients, right? Not to be confused by the race of the patient. And every other bar, minority patients, Black and Latino. And as you can see, all patients were more likely to receive an opiate analgesic, like a pain medicine, if they are white than their minority counterparts. And then they isolated for different types of illnesses. If you have a migraine, if you have back pain, if you actually have a bone fracture, you're less likely to get pain medicine if you're African American. And this was a big data study, but more importantly, this was a big, profound discovery, right? Somebody had to sit there and think, we're not treating our African American patients equally in terms of pain management. And that's a tough accusation to have, right? And then we have to ask, 20 years later, where are we at? It's pretty much the exact same data. This was a huge systematic review done in 2019 that showed Black patients are 38% less likely than their white counterparts to receive any analgesia, not just opiates, any analgesia for acute pain. And this was a systematic review, so high quality data, right? And this is 20 years, and every doctor should have been exposed to that initial study of we're treating our patients worse with pain management, right? We've seen it in kids. We've controlled for metropolitan, like inner city Chicago, versus non-metropolitan, like a suburb or rural Minnesota. We've controlled for socioeconomic status. We've controlled for a number of things. And we're really isolating into what the impact is, and it is individual racism causing this, right? Case 3. I hope you guys are still on board. We're flying through this pretty quickly here, okay? And so this is one of my favorites as well. A young Hispanic mother brings her 3-year-old child to the emergency department for the evaluation of head trauma. And the question is, what role does race play in reporting of abusive trauma in pediatric patients? And the reason why I love this one so much is because that is a benevolent thing, right? These doctors are waking up in the morning wanting to do the absolute best for their patients, and that is to report abusive trauma, right? And the next questions would be, if there is a disparity, what is this disparity and why? And so the bigger question would be, are minority children more vulnerable to abusive head trauma? And secondly, are we over or underreporting minority children for abusive head trauma? And to put in perspective, children who die from domestic violence, one of the major causes of child death, about 30% of them had a healthcare visit in the past year, right? So missing child examples of abusive trauma has been shown to have horrifying mortality on children, right? So accusing someone of abusive trauma is advocating for a patient, right? This is one of the most vulnerable members of society, right? A child. And so it's benevolent to want to make sure they're safe, right? But first and foremost, we'll answer that first question: are minority children more vulnerable to abusive trauma? The reality is, no, they're not. And so, and it's a mixed question, right? The reality is, if you have lower socioeconomic status, you are predisposed to have a higher likelihood of childhood maltreatment, right? However, at similar poverty levels, if you control for that, white patients are just as likely, if not more likely. This study in 2018 Journal of Epidemiology showed more likely than their African-American and Hispanic patients to have childhood maltreatment. And there's also this thing known as the Hispanic paradox, that Hispanics, even at low socioeconomic status, are much less likely to engage in maltreatment. And they attribute this to a number of things, like their culture, their immigration status, the religion, and also a number of other things. But it's been shown time and time again that this is the case, right? And therefore, are we actually reporting in an even manner that's justified by these stats? And what we found in this study in 2018, that minority patients were 2 to 4 times, Hispanic patients being 4 times more likely to have a reported of suspected child abuse for minor head trauma than their white counterparts. And this was a very narrow study, right? This is for patients who came in with a minor head trauma, not a severe injury, not a severe obvious example of child abuse, but a minor head trauma, right? Your kid falls off the swing, there's a bump on the head. And they also controlled for a number of confounding factors, including socioeconomic status. And the reality is once again, I'll hark on this a million times over. These doctors trained for 10 plus years to treat patients. They're most likely treating minority patients and trying to do their very best and doing a benevolent thing by advocating for their patients. But what is the actual effect this has when you're unfairly or without statistical background or evidence accusing minority patients more often, 4-fold more often than your white patients, right? First and foremost, you'll land in the New York Times, right? And this is a good example. This was done because of the study. A child bumps her head. What happens next depends on race. And it's pretty embarrassing and painful to see your management or any management that's representative of you found inside the New York Times. But even worse, all of your patients are reading this, right? This isn't just about public shaming. It's now every single patient who has a child and bumps their head has a concern that they could be treated differently and worse, accused of abuse, right? And let's talk about the deleterious effects this has on the actual children, right? How does this impact the family? One, if you get accused of child abuse as a child, you get full body x-rays, right? So these kids are getting exposed to full body radiation, right? There's the cost in the entire process of family defense attorneys. And given the fact that Hispanic patients are more likely to have questionable immigration status and also low socioeconomic status, and African-American patients as well, this is a very burdensome expense. Even time away from work is a burdensome expense, right? Any time of separation in foster care for children has been proven to be harmful, even in short periods of time. Foster care is very harmful to the psychosocial health of our children. But this is what really gets at me, right? And it's trust in our healthcare delivery, right? This group of patients is already at high risk for not wanting to engage in healthcare, right? They already have a number of factors that make it difficult for them to engage in healthcare, right? And now we have a deterrent based on their concern that they're going to be treated differently than their white counterparts. And what am I getting at? Why did I just present a ton of different studies and data on how there's a plethora of disparities in every different aspect of management, right? From chest pain and every category of chest pain management to pain management, something so simple as just giving Tylenol to somebody who's in pain, to accusing someone of child abuse. And really what I'm getting at is there's subconscious bias, and decades of racial disparities research has went into controlling every single possible confounding factor to convince us as physicians that we are engaging in racism through this thing called subconscious bias. Now, what is subconscious bias? It's synonymous with implicit bias. It's basically the idea that you have been exposed to American society in which a marginalized community has been repeatedly disparaged inside your psyche and in your presence, and through communication, through media, through a number of things, and also just through your observations in life, right? Like the effects of racism on these people and their low economic status and their other causes, right? And how it bleeds into your actions without you even knowing it. I have a fundamental belief that no physician in modern society spent 10 to 15 years to 20 years of training after a decade of education to wake up in the morning and be like, you know what, if I see an African-American patient, I'm gonna make sure I don't treat them the same as my white patient, right? But yet this keeps happening. And we have to question if we can prove where subconscious is. It's an incredibly difficult thing to measure if it's hard to even know it exists or if you're guilty of it. And one thing we've done is the implicit association test. I encourage everyone to, if you haven't been exposed to this or taken it, Google implicit association test. It's a phenomenal tool. It's developed by Harvard and University of Washington and University of Virginia in a joint initiative. One of the most popular and most cited psychological developments in the past decades in modern psychology, right? It's phenomenal, right? And it basically goes by race. You can do sexual orientation, you can do gender, and you can also do body habitus. There's a number of ways in which they've shown implicit associations, right? It's a great test and takes less than 5 minutes. I strongly encourage everyone to take a look at it. But the question is, one, it's a test, right? And does this test actually prove that we're behaving in a manner that's deleterious or harmful to our minority patients? And better yet, is there a clinical correlation is what I'm asking, right? So the first time they tried to prove there was a clinical correlation to the implicit association test was in 2007. And they took a big group of residents and they gave them a clinical vignette. These are ER residents and IM residents, because I like picking on my own ER, but IM got a little bit of included in this. And they wanted to know if they give them, their residents, a clinical vignette and change the race of the patient, will they offer the gold standard of care for a heart attack, right? And then they gave them an implicit association test. I'm sorry, they did the implicit association test first, and then they gave them the clinical vignette. And here's the data they found, right? There's two different parts of the study. Half the group was unaware and half of it was aware. The solid line is unaware. And what they found is if you have a high degree of implicit association, here at the bottom of the graph, you ended up treating your patients differently, which is measured on the left side of the graph. And this is an odds ratio. So if you have a 1-to-1 odds ratio, your Black and white patients are being treated exactly the same and offered the gold standard of management for a heart attack at the time. So what they found is if you had a high degree of implicit association, you were less likely than your low degree of implicit association scores to treat your patients exactly the same when you change their race on a clinical vignette. And that was the expected finding. However, if you look at when they were made aware of the study, those who took the implicit association test did poorly on it, had a high degree of implicit bias. They walked into that exam room and they treated every single patient exactly the same, right? That's crazy. And those who got a little comfortable, they had a low degree of implicit bias, actually did horrible on the test. They treated their patients completely opposite. And if this tells me anything, really, I want to go outside of every single patient room and put a sign on the door and says, you are a racist. So every single doctor walks into that room ready to do this 1-to-1 ratio of gold standard management for their patients, right? But really, it just shows you that, one, education matters. Understanding that there's implicit association and identifying it helps you. And then self-reflection. Immediate self-reflection can easily reverse these biases and management disparities, right? And so an excellent study, fascinating. It's been repeated in healthcare settings over 30 times. Ultimately, no test is perfect, such as the implicit association test, and clinical correlation is definitely difficult to entirely prove, right? But what can we do to fix these disparities, right? One, we can standardize practice and management. And if any of you guys are making a medical school, hopefully I'll have a chance to teach you something about emergency medicine. There's a number of decision aids and standardized practice models you can employ in every part of your practice to make sure that you're not adding too much subjectivity inside your management. And this isn't just for race. This is for gender disparities, sexual orientation disparities, body habitus disparities. All of these can quickly be fixed if we just standardize and make sure everyone's getting treated the same, right? We need to educate each other. We need to educate ourselves. This is a big proponent of pretty much every single education governing body in medical practice, including the ACGME, the LCME. All of them are proposing that we have more education on health equity, disparities, subconscious bias. And really, it's all about self-reflection. I don't want to have to do a study where I measure every single pain management scenario you're in and then give you a report at the end of the day to say you have been treating your Black patients less than your white patients, in order for you to identify that you have some biases in your practice, right? That's very accusatory. It's not helpful, and it's a drastic waste of resources, right? And I would propose this, right? We have a good example of a pandemic here that's given us a good idea of how to manage this, and it's a good analogy, right? When the initial pandemic started, we were quick to identify those with symptoms and try and control that. But what we found was that with a 50% asymptomatic rate, people needed to manage their lives and act as if they had the virus, right? And so I would advocate and suggest and challenge us all to act as if we have implicit biases, because we all do. I, a half Black, half Mexican American gay man who grew up in a low income area in San Antonio, have tons of biases, gender biases, a number of biases. I am a male, and so I go into these situations and scenarios where I have a concern for bias and try to address it and make sure my practice isn't affected by it. And I challenge everyone who's pre-med in here or doctors in here to do the same. What else? We're going to address race, the physician race demographics, right? And this is a clever cartoon saying that we're missing Black doctors in medicine, right? And so anytime I have a conversation about this, I like to start with the facts. I will not have a conversation with somebody without having data in front of us to see exactly what we're talking about, right? So we'll start with the racial makeup of the United States, and we will focus primarily on Black and Hispanic. One, I have a bias towards this, but two, these are our most commonly described underrepresented minorities in healthcare, right? So African Americans are 12.7%, that's the red part of the graph, and Hispanics are 17.8% of the US population. And in 2050, this is gonna greatly increase, right? Hispanics will be 26%, and white patients, white people will be, the green side will be less than 50% of the US population for the first time since we've started recording data. And let's look at physicians, right? Look how small these two parts of the graph get. Hispanics are 3% of physicians, Blacks are 5.8%. What about emergency medicine physicians, since I'm an ER doctor, right? And that African-American population is down to 3.1%, right? And then we can go into, are we getting better? What about, this is probably from decades of historic racism. Well, there's only 5% of emergency medicine residents in 2017 were African-American. So we are not gonna get to population parity of 12.7% anytime soon at this rate, right? And it looks like, have we improved? Is this better from decades ago? Actually, 2 decades ago, when they first started doing the demographics and ACGME started publishing these racial demographics of our residents, African Americans had more emergency department residents. And this is the case for pretty much every residency, right? And then we have to ask, what's the future look like? We're doing a little better with medical school at 7.3%, but it's not at all going to reach population parity at any time soon. And even more so in the Black population specifically, we've seen a great increase in the number of African American women who are educated or reaching higher education than our Black male counterparts. And this is a chart I showed for the first time when I was a resident at the Mayo Clinic, right? And Mayo Clinic is located right here in rural Minnesota, at Rochester, Minnesota. It's the #1 hospital in the country for I think the last 4 or 5 years now. And what I found was I was a hyper minority. I was the only Black doctor in the emergency department there. I was the only Black nurse, PA, nurse practitioner, any of the above, right? And so, and I felt that disparity. I felt it every single day. But then I had asked myself, is this the case just at the Mayo Clinic in rural Minnesota? In fact, I was the only Black male resident inside the entire state of Minnesota. And not just 1 year, all 3 years of my training. And then I looked and I noted that basically from Chicago all the way to the coast, I was the only Black male resident, including Alaska and Hawaii, to be a resident in emergency medicine during this time frame. And that is a time frame that covers 5 years, right? A half decade of education. Because when I started, the people 3 years ahead of me would have been covered in that time frame. And then when I finished, the people 2 years behind me are also included in that time frame. So a half decade of emergency medicine training resulted in no African-American men being trained in a quarter of the country. And I stopped the stats, and identifying this at the time was a little painful, to be honest. But the reality is I could color this entire map separate from maybe 10 states if we really dived into how bad the disparaging statistic is. There are millions of African Americans in this region. The other problem is I'm not from Minnesota. I left Minnesota, right? So the only Black men that they've trained in the last 5 years, a half decade, didn't even stay in the region to help the population that needs to be served. The other terrifying thing is if you are an African American male in this area, what would make you want to be the only one of something in this entire region as you're growing up and educated, right? That's a painful experience. So we have to, before we have a conversation about fixing this, really identify how severe the problem is. The problem is severe, right? And let's talk about how we can fix it. I strongly believe in affirmative action. I have a ton of biases that present for this. I remember being in college where it's a safe space, it should be a safe space, where we can have these nice, peaceful discussions about affirmative action. However, every governing body in medicine will be pro-affirmative action based on the last several years. And secondly, I would always advocate that we use the statistics before we have the conversation about it or the debate. And as I'm talking to a bunch of pre-meds who are going to have these debates in their dorm rooms, and that's part of the hidden curriculum of college, is to be able to defend your upbringing and have a diversity of opinion. But this is mine. And so the other thing we need to do is, in order to improve diversity, is remove bias from the metrics, right? Step one is a board qualifying exam, the MCAT, SAT, all these standardized tests have been shown to have devastating impacts on minority students and their ability to succeed, regardless of their economic status, regardless of region, right? The other thing we need is pipeline programs. If you've seen tons of these pipeline programs, I've been part of the summer medical dental education program. I went to Yale during the summer undergrad, and I was part of this. And the Tour for Diversity, there's a number of them. And I'm not saying you need to go out and start a pipeline, but you're probably going to be exposed to someone doing a pipeline, and maybe you can assist with it or respect the professionalism and respect that part of their professional qualifications to be a peer of yours or a colleague of yours. And lastly, I'm a strong advocate of this in mentorship. And this is Dr. Robinson. He was my mentor at Howard Medical School, so much so that I was called a Robinson man. It's like a kind of big thing. He retired the day I graduated medical school, and was very much a proponent and reason why I went to the Mayo Clinic. I call him daily, if not 3 times a week. And he's one of my best friends and also one of my greatest mentors. This is Jihan Khaledi. She is the wife of the program director, who should also be included in this for sure, of my emergency medicine department residency. It was her lecture on women in medicine that inspired me to have the confidence to do a lecture on diversity as a Black, half Mexican American male. And so I really appreciate what she's done for me. And this is Dr. Sadowski, and she was the chair of the emergency department at the Mayo Clinic, another group friend that I text and call all the time. We share books, and just a really phenomenal friend. And the reason I present these 3 particularly is because one is an African-American male, one is an Egyptian woman, and the other is a white American woman who has a father who's an ophthalmologist and went to an Ivy League school and knew nothing but privilege, and self-admittedly, right? And all 3 of these were phenomenal mentors for me. And so I'd advocate and challenge you, if you have an ability or a potential to mentor a student who's in a marginalized or underrepresented matter, or any student for that matter, do not be intimidated by the differences in your demographics. And as mentees, which is a skill set, you have to work on menteeship. I challenge you to look for mentorship in a variety of ways, not just in your own demographic, but certainly having an African-American male mentor was a phenomenal part of my experience. And now of course, I could not possibly talk about mentorship and leadership without bringing up Dr. Vo, who's invited me to this talk today.
Oh my
It's
God.
just a phenomenal part of, I know, right? I used to wear cornrows and that's why my hair is long. I still have long hair, guys. I didn't cut it. It's tied up in a professional manner. But honestly, Dr. Vo, seeing you in the Honors College is one of the few African-American teachers was an inspiration. Being able, from just that and visualizing you and seeing you in that manner was such an impactful part, but also just being able to talk to you on any given day about some of the impacts of being a minority in the Honors College or in general, and how comforting that was in a higher education setting. And also talking about historically Black colleges and universities and my desire to go to the Mecca, Howard. I only applied to one medical school, and I really appreciated you, and I could never thank you enough. But more so, Brenda, Sarah, and Franco, not just mentors. These are some of my best friends, and I keep in touch with them. This picture on the lower right is every single Christmas card that Brenda has given me over the last 7 years. I keep them all, Brenda. I have them, right? I've seen your kids grow up in front of my eyes. Obviously, this picture on the left, I shouldn't be calling her Brenda now. I should be calling her Dr. Ellis, but clearly I had a problem with this is right before I get torn into shreds by this finger right here, if you guys can see. And then we have Sarah Bajani, her husband, Jody, Franco Martinez, who's one of my best friends and mentors and just role models I aspire to be like every day of my life. And so much appreciation to these people in this picture. And so back to our conclusion, we talked about the impacts of structural versus individual racism, how we're using these terms, and how we can improve upon these disparities in both a structural manner and also individual manner. We talked about implicit bias, we talked about intervention, and we really talked about efforts to improve physician demographics and what the current state of affairs are. And so I open this up. I have about 50 minutes left, I think, to questions. I really appreciate you guys listening through. I know it was a lot of information quick, and it's something I'm really passionate about and excited to bring to you guys. And so thank you so much.
Wow. Excellent, excellent, excellent presentation. So much information. I was taking notes. I will be passing this along to my Black Political Thought students. Thank you so much, Josh. Let's get some questions going. Let's get questions, and you guys can just, I think, yeah, you can unmute yourselves and ask questions. If you want to put it in the chat, you can also put it in the chat and I'll read them.
Hi, my name is Zoha. To start, I wanted to thank you for this presentation. It was very informative and engaging. For my question, in discussions I've seen online, one really common comment is that people say that they want to stay neutral or don't want to get involved in the discussion about racism. But given the obvious racism that does exist within healthcare, do you think it's actually possible for someone to be a neutral party?
So I will quote Dr. Ibram Kendi. He's a new phenomenal artist, author, and he came up with a book called How to Be an Anti-Racist. There's this new movement, especially within Harvard Medical School, in which we're talking about anti-racism, because it's no longer enough to just say I'm not racist. And the reason being is if we do absolutely nothing, we leave every patient and every person alone in society and no longer consider race, the structural component of racism is already going to have a deleterious effect. You cannot, we have to go back and reverse this. And so honestly, my theory is, and not that people are evil, I don't subscribe to a good or bad, but it is not helpful to be neutral. It is not helpful, and you are just as much contributing to the issues at hand, particularly because your subconscious bias is a result of the effects of the structural racism, right? If structural racism causes people to be poor and you see people as poor every day, you're gonna treat people who look like that as poor in your general practice. And so the way I address it in a non-accusatory manner, you have to meet everyone where they're at, is that you need to make sure that you're attributing or applying a reversal strategy to some of the demographics. And that's my theory on the matter. Did that answer your question entirely?
Yeah, it did. Thank you.
Excellent. I strongly encourage everyone to read How to Be an Anti-Racist. It's the next phase in which we're, the civil rights movement that we're currently in which we're no longer attributing just not being a racist, which is something many people who are enacting policies that are harmful to and disadvantaging our minority patients is actually saying about themselves, right? Neutrality is no longer an option.
All right, Syed has a question. He says, how does eliminating the SAT, ACT, MCAT help promote greater Black minority participation in the medical field, I've always seen the SAT, ACT, MCAT as the greatest equalizer, since it offers everyone who takes it a fair shot at demonstrating their ability to go to graduate school.
I completely agree that there is a good argument at hand that this could be an equalizer in terms of people from every single school can compete on an equal footing. However, it's just statistically, we've seen it in every single category. It is disadvantaging our minority students. And so when you have an entire racial population doing worse on a test that is the biggest sole decider on where you can go to school and pursue higher education, we have to come to terms with this. Is no longer an acceptable means to measure students. And that's an opinion, and I am not in an admissions committee, and so, but it's definitely a well-known idea that we're starting to get rid of some of these things, including step one, which will be your first board you take, and prior to now was the most important test in terms of determining where you can do residency and which type of residency you can go in, is now going pass-fail. So they're no longer using these numbers in higher education or medical education. And so hopefully it trickles down. It was hopefully going to be an equalizer at some point, but it has shown time and time again to not actually be an equalizer.
Can I just jump in? Hey, Dr. Ellis, Josh, can I just jump in?
Hi.
You know, because I've done a lot of work on medical college admissions, and you're absolutely right. Wonderful talk, and it's also not very predictive. That's the thing, right? It's not very predictive of how people are going to actually do in their STAP exams, and certainly not how they're going to do in their clinicals. And so, you know, if it was predictive and if it was useful for success at med school, then that would be one thing. But it isn't, right? And so if it's doing that dual harm of not being particularly predictive and also being a point of exclusion, then that's why the conversation is quite so serious. So thank you.
May I ask a question?
Yep.
Oh, good evening, Dr. Ellis. I just had a quick question on whether, do you know of any research that shows that there are differences in the presence or effects of racial disparities among sex and race as well? So for example, like, is there more subconscious bias towards a Black Latino male versus a Black Latina female?
I'm sorry, repeat that question one more time. I'm sorry, I missed it.
So is there more subconscious bias towards a male of a certain demographic versus a female?
Oh, excellent, excellent. And this is intersectionality. The course I teach at Harvard Medical School is actually called The Language of Health Equity, in which we're defining these terms, and intersectionality is one of those. And what we can find is that being a female and a racial minority can have an additive effect. There's so many studies on gender disparities, just as much as there is studies on racial disparities in management. And so you're absolutely correct. There could be additive. Sometimes it's protective, but very hardly. And most studies demonstrate very much so that there's deleterious effects when you're having intersectionality inside these disparities. And that's in general, for sure. It's an interesting topic. Intersectionality was coined by Dr. Kinshaw in 1989. She did a whole presentation on it, and it was in response to the white feminist movement that didn't feel like the white feminist movement was actually including or asking that minority women or advocating for what minority women to be treated equally in society. And the way she defines it is saying that you cannot be pro-woman if you're against any racial minority, because there are racial minorities who are women. And I would say you cannot be pro-Black if you are homophobic, because there are gay Black men in society. And so all in all, if we're not addressing the intersectionality and the complexity of each individual person, you're not actually going to do in and of itself an adequate job of addressing some of these inequities.
So Dr. Ellis, thank you again for presenting today for us. But my question today is, it's about affirmative action. So I do agree with it and the good benefits that it does have, but at the same time, I have seen stories, and I do have, in terms of like my own social circles, I've heard of one story where people get into good schools and good programs just because they are a minority, right? They may not necessarily have the qualifications to do well, and they feel alienated, down the line. So I want to ask you, how do you think, we can reconcile this fact while increasing minority representation in higher education? Because I think it is good that we need more minorities in higher education, but there's going to be people who attack affirmative action because of this fact.
honestly, and my heart goes out to this complex and difficult discussion, right? Because there is a sacrifice to be had, and most likely it will be had by, not to be presumptuous, but Asian American and the subcategories of Asian Americans will have to feel the ramifications of affirmative action. But my theory and my point is that the numbers are just too low, right? We're talking about if you're not indifferent, if you're completely indifferent to the fact that I colored a quarter of this country with being the only Black male inside training in emergency medicine, it's just really difficult to supersede that priority for me. And that's what I'm doing. I'm prioritizing an initiative over potentially a harmful thing. And what we've also seen is that minority providers are succeeding, right? I'm an example of it. And I'm definitely, there has to be some component of affirmative action inside my education. But that's how I argue it. Fortunately, I do not engage in the conversation a lot because I know it's passionate. And in Harvard here especially, the 2019 Supreme Court case was the Students' Fair Act. I might be mispronouncing or stating that, but against Harvard University. So it's a passionate subject here. But I would always bring up the statistics. And Harvard is a good one, right? 25% of that campus is Asian American, and we're still barely at 10% of one of the major diversity initiative campuses in the country of minority African American patients. And so I would always bring up the statistics and say we have to have a level of difference and concern about the statistics. But it's definitely a difficult discussion. That's why it's going to the Supreme Court time and time again.
I'm going to put two questions together. One person was asking about how you deal with the biases of the patients coming in, so the prejudice or the bias of the patients. And then someone asked if you have some advice for minority patients on how they can kind of advocate for themselves in the system.
I will start with the first one. I am a super friendly person, right? And I also have a drastic diverse background, right? And as a half Black, half Mexican American gay person who grew up in low income, poor area of San Antonio, who now lives in the bougiest, richest part of Boston, I have a reason for somebody to hate me in every category of life. And so I've just had a good experience at being able to walk into a situation and try and diffuse and address some of the concerns I have. I think I have a really friendly, aggressively friendly personality when I walk into the patient room. And the reality is emergency department patients are unique. They're very vulnerable. They want the best care for their family member, themselves. And I have to quickly prove to them that this young Black male, which if they grew up or if they were in that quarter of the country, they have not ever seen one of me in my profession, right? And I have to convince them that I'm going to do the best job at giving them adequate care. And so I make it a huge priority to go in there extremely friendly, not get offended, non-accusatory, and just meet people where they're at. Now the patient, it's really hard to answer that. I have a brother whose fiance just gave birth to our first grandchild in the family, and she didn't engage in healthcare because of her distrust for it. And so it's really tough. And the reality is I would always advocate for yourself, educate yourself, and educate a patient who can Google the diagnosis, Google what they're saying, write down what they're saying, and try your best to keep up with the conversation. And easily, a lot of these doctors are getting their information from Google. And if you can tell them the gold standard and find a source for it, you can advocate for your management. But I would say continue to engage in healthcare. Don't be afraid of it. Advocate for yourself. And that's my own personal opinion. I don't have any metrics or studies to prove that that's useful.
Hey, great presentation, Dr. Ellis. My question is, as a Black physician, besides mentorship, which I completely believe in, how can I influence my colleagues from different backgrounds to make these decisions not based on bias without being divisive?
I am a huge proponent of a non-accusatory approach to this difficult conversation. There's a number of times where I'm in a healthcare setting and members of my healthcare team who are practicing under my license could have been perceived to have had a racial bias toward a patient, and that changed the management of the situation. I am a proponent of non-accusatory approach. You lose people at the door when you're making them feel bad for it. I don't subscribe to the good guy, bad guy model of this conversation. I have a full belief, thanks to Dr. Gunther's class, that if I grew up in the 1930s in Germany as a white, blue-eyed person, I'd probably engage in mass genocide, which is crazy to say, but the reality is these people need education, and they need it in a non-accusatory, safe education model. And I think that's the point of some of these lectures. And so I would try my best to be friendly and non-accusatory in the correction, but that's a difficult conversation, and sometimes in more egregious cases require a different approach. And so thank you, Dr. Dewberry. I think I recognize your voice.
All right, we have so many questions. Unfortunately, we have run out of time. If you will take your mics off of mute, and let's try to give Dr. Ellis a rousing applause. Let's,
Yay!
well done.
Very well.
Very good. Thank you all.
Thank you guys so much. Thank you, Dr. Lowe.
Josh, Ellis, for spending your evening with us. We really appreciate it. It's so good to see you. And don't be a stranger. Come back.
Sounds good. After Corona, I'm coming to do this in person. I love it.
All right, we're going to hold you to it.
Thank you so much, Dean Moreau.
Thank you.
All right. Thank you very much. Everyone have a wonderful evening.